Hello, my name is Anaya Webb, and this is my week 6 return to demonstration over the heart and neck vessels. For this demonstration, I do not have a patient, so I will just be using myself and demonstrating certain parts of the demonstration on myself. I do have my stethoscope with me to show how it will be used for certain parts of the assessment. So to begin the assessment, of course, I would start off with hand hygiene before I enter the patient's room. I would knock, of course. I would start off with aided, and I would introduce myself to the patient and let the patient know that I will be their student nurse for today, and I will be completing an assessment over their heart and neck vessels. I would explain to the patient that it would take about 5 to 10 minutes, and of course, I would thank them ahead of time for participating and cooperating as I'm completing my assessment. So before I begin my assessment, of course, my patient will be dressed in a gown with no shirt so that I'm able to palpate and auscultate and inspect over bare skin. Of course, my patient will be sitting upright and will be sitting in an erect position. First, I would start off with inspection. So I would inspect my patient's skin tone. If there is no abnormal findings, I would note that the patient's skin tone is consistent and even throughout and that it is appropriate to their race. After I have inspected the skin tone, I will next inspect their carotid pulsation, and if there is no abnormal findings with that, I would note that they have a mild carotid pulsation bilaterally, which is that I'm able to see their carotid pulsation on both sides of their neck. After that, I would check for JVD, which is jugular vein distension. When a person is sitting up, there should be no signs of JVD. So if there is no abnormal findings with that, I would note that there is no JVD. After that, I would inspect their precordium. Upon inspection, I would just look at their posterior, I'm sorry, not posterior, anterior precordium. And if there is no abnormal findings with that, I would note that there are no lifts or heaves as I am inspecting their precordium. After that, I would check for any signs of pedal edema, which is fluid buildup or fluid buildup or swelling, within the person's foot or ankle. So I can see that upon inspection, just by looking and seeing if they have any signs of swelling or edema. And if there is no abnormal findings with that, I would state that there is no pedal edema. Next, I would also, I'm still in the inspection part. So the person was sitting up at first. Now I will have the person laying down. And on this part of inspection, I would check for their JVD. So I would have the person lay down flat. I would remove pillows if the patient is laying on a pillow. And I would have the person turn their head to their left side, and I would have to stand on their right side to inspect their JVD. When they're laying down, they should have their JVD should be noted. You should be able to see that. I would have the person sitting up at a 45 degree angle. Once the person sits up, there should be no signs of JVD once they're sitting up. Next, I would go to palpation. So of course, I would palpate for the capillary refill. So I would check within their fingernails, and their capillary refill should return back within 1 to 2 seconds. If they have no abnormal findings with that, I would note that their cap refill is normal. After that, I would palpate for their carotid. So when you're palpating for a person's carotid, you want to not palpate them simultaneously because you can have the person to pass out. So as I'm palpating for their carotid, I would feel right here in their neck, and I would check for that their rate, rhythm, and their rate and rhythm is regular. So of course, if there's no abnormal findings with that, I would note that their carotid pulsation is regular. It has a good rate and a good rhythm, and I would check that on both sides of their neck one at a time. You never want to palpate them simultaneously. After that, I would check for the person's apical post. So when you're checking for the patient's apical post, it's always between the fourth and fifth intercostal space. If you're palpating for that post with a male, it's pretty easier to feel. If you're checking it with a woman, you want to check under their breasts, so you're able to feel that post, and you're able to feel that there is a good rhythm and rate with that. And as I'm feeling for that post, if there is no abnormal findings, I would note that the span of that apical post is 2 centimeters, which is normal. After that, I will auscultate, and that is when I would, of course, use my stethoscope. And for auscultation, you can use the bell. I'm sorry, this is the bell or the diaphragm. So as I am auscultating, I will you can auscultate for the apical post for that, and I would check for their I would note that their apical post is regular, it has a good rate and rhythm. Next, after I am listening for their apical post, I would check for, I will auscultate for the 5 anatomical positions. So with that, you can use either your bell. You want to use your bell, your bell. I'm sorry, you get confused. You want to use your diaphragm and then your bell when you're listening to your 5 anatomical spaces. So as I'm listening, I'm going to try to do this upon myself. So I have my 5 anatomical spaces. So of course we have the aortic valve. It might be hard for you to see, but I'm just going to point. So if I am facing the other way as I'm listening to my patient, I will listen for the aortic valve, which is the second right intercostal space. And then of course you will listen for the pulmonic valve, which is the second left intercostal space. So it might look backwards the way it is I'm sitting in the camera, but if the patient was turned around, this would of course be the aortic, which is the second right intercostal space, and then you have the pulmonic, which is the second left intercostal space. And of course, after that, you have tricuspid. So when you're listening to this for, like I said, it's easier for a male, but for a female, of course, you want to listen up under their breast, so you want to lift their breast up. So we have the tricuspid, which is the left lower intercostal space, and then left lower sternal border. And then you have the mitral, which is kind of a little bit ways under the tricuspid. The mitral is the 5th intercostal space. And then you have your herbs, which is your left sternal border, and this is also considered your 3rd intercostal space. So you have 5. You have your aortic, pulmonic, tricuspid, mitral, and herbs. And as I'm listening to those points of the heart, of course, like I said, you would start off with your diaphragm, going through each part, and then you would flip it over to your bell so that you're able to hear for different sounds at lower high pitches. So that is why they say you use your diaphragm first and then your bell, because you're able to check for any signs of murmurs or anything. So as I'm listening to that, I would note that I'm listening for my S1 and S2 sounds, and I would note that S1 and S2 is present, and that my S1 sound should be louder at the apex and the S2 sound should be louder at the base. And when you get to Erb's point, your S1 and S2 should be equally. So if that is normal, I would state that, their S1 and S2 is present. S1 is louder at the apex. S2 is louder at the base. And at Erb's point, S1 and S2 is heard equally. And then I will also note that there are no signs of murmurs, because you can hear murmurs through the bell more often than through the diaphragm. After that would be the end of the assessment. So I would end the assessment with Roth. I would reassess the patient's pain, make sure they don't have any pain level. I would have them score their pain from 1 to 10. I would also make sure that the patient is comfortable. I would ask them if they need anything extra, or if they have any questions that they would like to ask. And I would reassure the patient that if they do have questions or they think about anything when they leave from the visit, they're always welcome to come back and talk with us, or if they feel anything is wrong, always come back in and check. We're always here. So once that is done, once I have reassessed their pain, check if the patient is comfortable, if they need anything, of course I would thank the patient again for allowing me to complete my assessment, and I would thank them for being cooperative. And then I would, of course, hand hygiene before I leave the room, and that's it. Thank you.